Good afternoon, everybody, and welcome to this lovely afternoon with the presence of Professor Enrico N from Munich, who is visiting us today, giving us the pleasure to listen to his talks. Professor Enrico N is Professor of Oncology. He is the head of GI Oncology in Munich University. And he's the Vice Director of Liver Cancer Center as well in Munich University. He has a lot of, I would say, academic interest publications with an H index reaching 35. He's working with his team in many randomized studies, including studies saying immunotherapy in HCC with TACE for the intermediate stage, and immunotherapy plus minus radioembolization as well for HCC. So welcome, Professor. With us.
Well, dear Director, ladies and gentlemen, thank you very much for having me here. And Director, I hope I make a better impression now after the coffee. I don't look that tired. I'm not tired. I'm really excited to be here, and it's really an experience to visit this part of the Gulf these days. And I'm astonished at the level of sophisticated level of knowledge and infrastructure you have. And I hope that my visiting here will offer the chance for quicker cooperation and interaction. But thank you for having me here today. I will start the first presentation on the topic of the development of immunotherapy for hepatocellular. First of all, these are my potential conflicts of interest. As I always say, that bias in every possible direction to every company. I think that net results of this bias would be a neutral opinion on what we are talking about. And second disclaimer, I would like to thank company AstraZeneca for inviting me. He has paid me for this travel, and the travel expensive. And I'm talking about their product, but I'm not going to advertise their product. Because this fitting, please let me know, and I would be glad to be challenged to discuss the real relevance of this company's product in the landscape of the HCC. So the BCLC algorithm, I will be talking about the treatment of patient in advanced stage, and this is the treatment setting of BCLCC patient with metastatic disease or vascular invasion, which defined as systemic disease for hepatocellular carcinoma. But you see that at some point, the systemic treatment tend to push towards the left of the algorithm in the field of BCLCB, because some patients with BCLCB HCC are probably not suitable for the treatment. But first of all, just 3 slides about tyrosine kinase inhibitors. I don't know whether you had experience with tyrosine kinase inhibitors or to which extent you had experience in the setting of treatment of HCC patients. But the first slide reflects the basic idea on the pathophysiology of HCC in the years 2000, and basic approach to cancer treatment those years. We thought we had understood so much or so well the complicated and entangled network of different signaling pathways supporting the pathophysiology of hepatocellular carcinoma. They would be able to selectively and in a tailored way block the signaling pathway in individual patients. So the idea was they would be taking a biopsy from a tumor tissue of this patient, recognize which pathway would be deranged, and then give one of the corresponding tyrosine kinase inhibitors. You see some of them here together. And the first instance of this process, the very first trial which has been conducted with tyrosine kinase inhibitors, HCC, was sorafenib. Sorafenib was initially designed as a RAF inhibitor because the RAS-RAF-MEK-ERK signaling pathway is very often deranged in cancer. It would be a good idea to design a drug which inhibits the signaling pathways in advanced HCC. And the trial was a triumph because we had 3 months survival advantage versus placebo. At that time, it was still possible to do a phase 3 trial with placebo, but nevertheless, it was a major achievement and proof of principle that hepatocellular carcinoma could in fact be treated by systemic treatment, which was thought to be almost impossible. And we thought that this would be a triumphal march of positive trial. Instead, 10 years elapsed and we had no other positive trial for quite a while. So all these trials were negative until, to make a very long story short, we had, through a process of trial and error, positive results from, for instance, the lenvatinib trial versus sorafenib. It was not even a superiority trial, it was a non-inferiority trial. So no big leap forwards, but nevertheless another weapon to treat HCC. And then within 2 or 3 years, there were also some other positive trials that were graphing to ramucirumab. So to wrap up the story of the development of tyrosine kinase inhibitors, hepatocellular carcinoma, we established through a process of trial and error, finally a sequence of treatment based on tyrosine kinase inhibitors, which actually proved beneficial for the life and survival of this patient. Yeah, this is a real life cohort from a fellow of mine, Enrico N, who has analyzed data from several thousand patients, data provided by an insurance company, and he could demonstrate the fact that the availability of several lines of treatment beyond sorafenib also translated into an actual increase of survival in these patients. But then came the revolution of the immuno-oncology. As you know, those two sides have been awarded the Nobel Prize because the fact that they have discovered 2 main negative receptors of activity of T cells, CTLA4 and the PD-1. As if you still have in mind the first very complex and tangled description of the intracellular signaling pathway in hepatocellular carcinoma, you see here that the concept has changed radically. The immune checkpoint inhibitors do not possess per se an anti-cancer effect. They do not poison, so to speak, the tumor like chemotherapy do or cytotoxic drugs. Instead, they release the inhibition of the immune system, so the immune system can recognize the tumor non-self, and this results in tumor-specific attack from the immune system. And this is one of the first patients who had ever been treated with immune checkpoint inhibitors at our institution. At that time, nivolumab was available as for off-label use, and there was this patient who presented with an exophytic growing mass, will not be candidate for a surgery, of course, because he had extrahepatic spread and even a brain metastasis. And we administered him nivolumab as a salvage strategy, and after 3 months, the tumor was gone. So we really thought the immune checkpoint inhibitors would be a game changer. But unfortunately, as you probably know, the first study using nivolumab alone was negative against sorafenib. You see here a very characteristic effect of immune checkpoint inhibitors, the long tail of the curve separated at a later time point, but median overall survival was not significantly different. So first trial of immunotherapy for hepatocellular carcinoma based on monotherapy with nivolumab was a negative trial. So what could we do about that? So the situation was we had on the left side there's several different tyrosine kinase inhibitors and one antibody VEGF available, which were effective alone and approved against hepatocellular carcinoma. And then we have 2 different checkpoint inhibitors which were well established in other tumor entities, but not effective, at least not superior to standard of care in the treatment of advanced HCC. So the idea would be to combine every checkpoint inhibitors with tyrosine kinase inhibitors, and we have basically 3 different possibilities: 2 checkpoint inhibitors, 1 checkpoint inhibitor, tyrosine kinase inhibitors, 1 checkpoint inhibitor, VEGF inhibitors. So I would like to show you very briefly in the next 3 slide sections what we did to test the effect of these 3 possible combinations. And I would like to start with the IBRAE 150 trial, because it was the first trial to combine 1 checkpoint inhibitor and 1 VEGF inhibitor. And as you all know, it was a large randomized trial 2-to-1 randomization for patients with local cancer metastatic or resectable hepatocellular carcinoma versus sorafenib at that time, the standard of care. And obviously, these patients were selected. Every trial leads to patient selection because of the need of having homogeneous population. But the specialty of this trial was that it was the first time that bevacizumab was used in HCC patients. And as you know, HCC patients are particularly vulnerable patients as counts as the likelihood that might suffer an episode of bleeding because the impaired coagulation owing to concomitant liver cirrhosis, the esophagus varices, the leukemia. So there was a strong focus on exclusion on patients at risk for bleeding or with cardiovascular disorders, and especially patients who had esophagus varices. So all these patients need to have an EGD prior to inclusion into the study. So you have to keep this in mind to interpret the EGD. First reaction and the results of the trial. But the trial percent intention to treat population was a huge success. There were about 6 months additional benefit in terms of survival compared to sorafenib. The standard of care at that time has a ratio of 0.6. So a very successful trial. Keep in mind, of course, if you consider the likelihood of adverse reactions, the hemorrhage, and the gastrointestinal bleeding was a problem for some patients here, even though they had been selected for not being included in as come to the baseline characteristics. So this highlights the potential danger of using a VEGF inhibitor in the treatment of hepatocellular carcinoma. Very quickly about the safety, you see here the high-grade adverse events in 3 or 4 highlighted in the darker color. If you compare them with those of sorafenib, you see that the safety profile is quite acceptable and comparable to that of sorafenib. What was absolutely superior was, beside the efficacy, also the much better tolerability of immunotherapy compared to sorafenib. This curve showed the decline of the performance state of the patient, and this decline with sorafenib was much steeper than immunotherapy. So basically, this was an effective treatment option. One should be careful about the possible complications related to bleeding, and it was tolerable, and the quality of life is much better. Now we come to the difficult issue of subgroup analysis. As you know, being oncologists and being active in the field of oncology, we have an intention to treat population with respect to which the trial has been designed, powered to measure median overall survival. And there are stratification factors which ensure that there is no major imbalance in the two group objects of the scrutiny with regard to the primary endpoint. But we have here also subgroup analysis, something we make afterwards. And if we look at this subgroup analysis with a bit of caution, because you're possibly imbalanced, since the study was not powered to look at this subgroup analysis, you see here that there are 2 groups, BCLCP and non-viral hepatocellular carcinoma. They don't seem to have such a big benefit as the general population of patients. But that again, the subgroup analysis. And then another important subgroup analysis is about the liver function. I think we all use the Child-Pugh score as daily standard for evaluating liver function. Most of you, I think, are surgeons, and Child-Pugh, I think they were either surgeons or they did that for surgeons. This is a surgical score. But nevertheless, we have also the IB grade score. All those patients who were child A as a standard for inclusion not in any clinical trials, they preserve liver function. But nevertheless, for the child A liver cirrhosis, you can distinguish 2 categories of liver function based on the IB grade. So some kind of more precise way of distinguishing liver impairment. And if you divide the patient according to IB grade 1 and 2, you see that probably IB grade 2 patient did not profit as the general population from the treatment with atezolizumab. So this is the IMBRAVE study, assessing the strategy one checkpoint, one GF inhibitor. What happens with the second study would address the same issue. In this case, with pembrolizumab, one checkpoint, rigosertib, also VEGF inhibitor, but in form of tyrosine kinase, in our respect of tyrosine kinase, and the study was positive. So I'm not going longer into this study because it's just confirms the concept we're talking about. One checkpoint inhibitor, VEGF inhibitor, is a winning strategy. So this is atezolizumab as a standard of care. So what happens now if we take two checkpoint inhibitors? And this brings us to the Himalaya trial and to the assessment of tremelimumab and durvalumab versus sorafenib, with the trial including also durvalumab alone study. And the primary endpoint was superiority of durvalumab versus sorafenib. And the baseline characteristics were well balanced across the groups. And we came to the primary endpoint of the trial with overall survival. The study was positive. You see a very big separation of the Kaplan-Meier curves. The peculiarity of this trial was that we had a 36-month overall survival rate as a pre-planned, pre-specified endpoint of the study. And this endpoint showed that after 3 years, still 30% of patients were alive, which is something unheard of until that moment in the era of tyrosine kinase inhibitors. And there was a secondary endpoint, the non-inferiority of durvalumab versus sorafenib, which was also positive. Now we have considered the subgroup analysis for atezolizumab. We look at subgroup analysis of durvalumab. We search for weaknesses in the subpopulation, which is a subpopulation who might not have such a big advantage in being treated with immunotherapy compared to sorafenib. We have here subpopulation with hepatitis C. This population, I would say, it might not profit as much as the current population. But as I said, subgroup analysis is somehow always a bit dangerous because it might be biased, but balancement of baseline characteristics of these patients. And if we look at these baseline characteristics, in fact, we see that there was indeed an imbalancement due to the fact that extrahepatic spread and a worse liver function were overrepresented in the patients with hepatitis C virus positivity. And if you normalize this baseline factors, you look to see a shift towards the left of the hazard ratio in subpopulation, which almost reverts this apparent disadvantage which we observe in the current data analysis. As kept to safety tolerability, we take, for instance, any grade 3 or 4 adverse events, and we can see that we were almost comparable between durvalumab and sorafenib. And if you consider the most dangerous, if you will, side adverse reaction in patients with hepatocellular carcinoma, you see here that the hepatic events were rare altogether and comparable across the study arms. You take, for instance, grade 3 or higher, there were 7, 5, 2, and 4 cases, comparable in sorafenib, durva, and durvalumab arm, and the number of the vasovarizes hemorrhage was exactly 0 in all 3 trials, which highlights the safety of the bevacizumab-free regimen. Now, last group analysis was about the liver function. We have seen that a worse liver function, as judged by the IB grade, could be detrimental for a patient with atezolizumab. If we take a look now to this graph separating patients according to whether they had a better or worse liver function, we can see that both populations equally profited by the administration of immunotherapy based on durvalumab. So now very quickly to the third possibility, what happens if we combine one checkpoint and tyrosine kinase inhibitors. In fact, we would expect this to be the most effective option because in addition to being sensitized to immune checkpoint inhibitors and VEGF inhibitors themselves, tyrosine kinase inhibitors possess an intrinsic effect against tumor cells. So we would expect it would be the ideal combination, and the signals from phase 2 trials were excellent. But if we now take a look to the reality, we have here a trial of cabozantinib plus atezolizumab, and the trial was encouraging and positive as compared to PFS. but it was negative as come to overall survival. So response and tumor control is not everything. Just if we consider the theoretical aspects of the slide, then the other disappointments you see here is still the original slide from the lecture of Richard Finn was the use of the lenvatinib and pembrolizumab, and the lead to the trial was also negative if you judge the separation of the curves in the region of the median overall survival. Of course, it was a separation of the T, but the trial was not powered, it was not determined to measure a late time point, median overall survival. In the study was negative. So altogether, we can see, as far as we understand now, multi-tyrosine kinase inhibitors with a broad spectrum of inhibition are probably not best candidate for association with immune checkpoint inhibitors. And we come to the wrap up. This is the current state of the approval in Europe, and perhaps that will reflect the state of approval in the region. We have got immunotherapy with durvalumab or atezolizumab, all legitimate option and first-line treatment. And then we have the use of tyrosine kinase inhibitors in the same sequence in which they had been established before immunotherapy, sorafenib or lenvatinib, followed by the other three options. Well, and this is reflected in the BCLC treatment algorithm and in the NCCN guidelines, and of course in the ESMO guidelines with equal evidence regarding the clinical benefit scoring. So to summarize the chapter of immunotherapy, we have two regimens for first-line treatment, atezolizumab and STRIDE. STRIDE is the name which was chosen to define the treatment with durvalumab and tremelimumab, and both regimens can be used for first-line treatment. You have got equal dignity, if you want to say so. Question is, which one do you want to use in individual patients? Is up to you to consider some factors which might influence the success of these drugs. And one of this is the use as a possibility on the availability of a bevacizumab-free option. Perhaps you will be more inclined to use a bevacizumab-free option in patients with esophagus varices, with cardiovascular disease, or at risk of stroke, or pulmonary embolism, and other similar diseases. And you might consider pathology and liver function as factors based on the post-hoc analysis and subgroup analysis, with the big caveat or warning that subgroup analysis do not give us the certainty about the effect of a certain baseline characteristic, but indication about possible difference of these characteristics. So this is the first part about the systemic treatment. If you want, we can discuss it now before we proceed to the second part of the presentation.
Thank you very much for this excellent presentation. I really enjoyed it. I got a couple of questions. My first question is regarding what would be the first line, the atezolizumab or the STRIDE regimen. I'm sure you heard this comment maybe around the Gulf, that the median overall survival for atezolizumab in I believe 150 was 19 months point something. Now, if we look at the median survival here, we have reached 16.2 months for the STRIDE regimen, and for the durvalumab regimen, I think 16.9 months. Now, those who don't have contraindication, like advanced esophageal varices, what would be the approach? Would they be served better by having a combination of atezolizumab? The second question is the priming dose of tremelimumab. What does it do? Because if you look at durvalumab as a single agent, the median overall survival is almost the same. Do we need that priming dose? What does it do? Does it help? So those patients who are not candidate for atezolizumab, they just get durvalumab as a single agent without complicating the regimen by adding, giving them the stride protocol.
Well, thank you. Both questions are absolutely legitimate questions and very clever questions. And that's the question we are hearing very frequently and debating very, very often. So, but let's come to the first question. I must admit that at first myself, I have seen the median overall survival of durvalumab, and it was a bit disappointing. But of course, I reminded myself, you never do cross comparison between trials. You do not compare two trials which recruiting patients at different time points at different characteristics. So this is a classical explanation. But nevertheless, we do that. And we have the inner filling, so the belly filling, that if a study has got lower median overall survival, so probably this study, which is lower than another study in a similar population, this regimen is probably inferior. Until, however, I have been again disappointed, not by durvalumab, but this trial here. This is the pembrolizumab trial. We had here the combination in a phase 2 trial, and if you take this is a negative study, and the median overall survival is also 21 months, but yet the trial is negative. So this gives you an instance on how different baseline characteristics of patients which have been recruited in different parts of the world at different time might influence the median overall survival. So by this time, I thought perhaps we should really do not take median overall survival as an absolute value, as a measure of effectiveness of one regimen and do a cross comparison. This is the first answer to the question, why should we prefer one regimen over the other with regards to the effectiveness? And the second point, which is object of the second section of my talk, is what is important to us. Is it really median overall survival, or is it something different? We have seen in one of the last slides that PFS is not a good surrogate of clinical benefit because it might be very large in cabozantinib atezolizumab trial, but does not reflect an increased overall survival. But the next question is, what is really important to us? And to this regard, I would like to come to the topic of the long tail of the curve. Now, what is important to me and became increasingly important as I regarded the results of the STRIDE trial was that the trial is the only one which tells us, according to a pre-specified endpoint, that the likelihood that the patient is still alive after 3 years is equal to approximately 30%. And this fact percent is to me very important if you look at this slide. This slide compares two different kinds of cancer treatment. This is the classic hypothetical Kaplan-Meier curve of cytotoxic therapy or tyrosine kinase inhibitors. And you see, we have a clinical benefits concentrated at the beginning of the curve, and eventually all patients die and approach the control curve. Now we have got here, this is cytotoxic chemotherapy or tyrosine kinase inhibitors like sorafenib, and this is the effective immune checkpoint inhibitors. You have got a rapid decline of survival. So a bad median overall survival, if you overlap this gray curve with this curve, but you have a long tail. So if you're lucky enough to survive the first, let's say, 2 years, then you're almost sure you're not going to die due owing to a tumor. So that's, we put a bit provocatively, but that's the concept. So the tumor-related mortality is really very low. So my provocative question to you is, which curve do you want to be on? Do you want a high likelihood of enjoying an increase of your survival to some extent. Tell you, I will get 80% likelihood that your life is going to increase by 3 months. Or do you want to bet on the less likely possibility that you're going to belong to this 25% patient who you're still alive?
We see this with atezo-bev. We say that even in the updated data from the initial publication, the survival benefit is maintained for those. And we see it clinically. We have patients who are surviving for 2 years on atezo-bev, those ones who survived the initial phase.
Yes.
So the question is, which one would be your first line, atezo-bev or the STRIDE regimen? What we tended to do, that it is atezo-bev. If they have a bleeding tendency, then we go for durvalumab single agent, because I really don't believe that the priming dose of the TONI is adding too much to the whole. This is my point of view.
Yes, this is the second question. Why should we use the combination, or should we use just one drug? So the first question, I understand your point of view. You say, if a patient can receive atezo-bev, I don't give him STRIDE. I give him atezo-bev, because we don't have a long curve, because we don't have the corresponding data. They're not be published for 3 to 4 years for atezo-bev, but nevertheless, you believe that the curve is long. And the survival measured, the median overall survival trial was higher. So you see, you've got the feeling that atezo-bev is better. We don't really know that, because the trials have not been compared to each other. But the instance with pembrolizumab really tells us that median overall survival varies a lot across trials, and this somewhat speaks against the argument of taking a median overall survival in the atezo-bev trial. And then there is a second question: should we use the combination, or would it suffice to use durvalumab? And I wouldn't do so. And I've got 2 arguments. And the first argument is that we do not do phase 3 trial without a very strong statistical assumptions about our target population. And the STRIDE regimen was not, the STRIDE trial, the malaria trial, was not powered to see a difference between durval training and durvalumab alone. So if we do not have evidence about the equivalence of the 2 different arms, we should not treat our patients with one arm.
And it's superior to sorafenib.
It's not inferior to sorafenib, durvalumab. So, and we have consistent data about the use of
the ratio 4.72, I think.
Yeah, but
similar hazard ratio on both arms, median overall survival.
Yes, that suggests that durva alone could be effective. But if you take nivo alone, like the trial of checkmate for 59, and if you take the data of pembrolizumab alone, we have seen that checkpoint inhibition alone is not as effective as the doctor pointed out.
It was a phase 2 data for pembrolizumab, and then it's negative, and then for the nivolumab, initially positive, then it became negative. So on the phase 3 data, so it's slightly different. Here we have 3 arms, and the 2 arms, the STRIDE regimen and the nivolumab alone, almost identical.
Yes, but the trial was not powered to compare them. There hasn't been any statistical comparison, and I think we should not treat our patients if not based on the evidence. And the evidence we have got from phase 3 trials, which is sufficiently powered to compare to different populations. But I understand your point of view. You
So
look at the curve,
Also,
and it looks similar.
The NCCN background, they put the durvalumab alone. It's not my only point of view. It's there. I know that NCCN are not applied everywhere in the world, but actually it is recommended as a single agent.
Yes, I mean you can do that, of course, but I would not have the feeling that you would have exploited fully the treatment. And if you take, for instance, some secondary endpoints like duration of response, you see that in the combination of durvalumab, I don't think I have slides here, but you see that the combination with durvalumab in comparison to durvalumab alone has much longer duration response.
I think that's not. Just one quick question. Ideal scenario is child A, but in the clinic, most of our patients are actually child B.
Absolutely.
What do you do? Because according to the data available, we should not use atezolizumab, any of these, except sorafenib. There is some data in child B. What do you do yourself in clinical practice with child B?
Yes, I think we do the same. Namely, we treat patient anyway. So, concerning sorafenib, I also contributed to write as part of the German guidelines on sorafenib being a possibility for child B7 patient for SSFA. But really, we do not have data about it. There is data of the DEALN trial showing that it progressive decline of the Kaplan-Meier curve with increasing child points. But we have never had a head-to-head trial in child B patients because it's very, very difficult to perform trials in this details. But in this case, very straightforward. I would use STRIDE for this patient. Why STRIDE? Because well, it's not evidence-based, just belly feeling, if you want to call it so. But if you look at the subgroup analysis based on the ALBI score, so there does not seem to be any difference in ALBI score 2 in patient treated with STRIDE. While if you take patient treated with atezolizumab, there was a marginal difference or no difference in the ALBI2 patients. So if you ask me what it would do, I would give them STRIDE. But what would you do?
We individualize. If the patient is still suitable, we will go for atezolizumab. Many times we give only KPIs in this category of poorer patients. We reserve.
So what do you do? What do you do?
Sorafenib.
Sorafenib. Okay.
Poorer category patients, we give sorafenib.
Okay. So I think we addressed 2 very important questions. We do not have final answers. The first one was the choice with the initial regimen. And I understand your feeling that nevertheless, high median overall survival 1 trial might be a sign of better effectiveness. My point of view is that more than median overall survival, we need a regimen who delivers a long tail of the curve. Right, you have a feeling that atezolizumab also provides long-term survival in these patients. But the data on this point we have only from the STRIDE regimen. And keep in mind, of course, this patient who are treated with atezolizumab receive bevacizumab, have to receive bevacizumab for a very long time. We do not know what the effect of long-term administration of bevacizumab in this patient. But again, that's speculation and my personal point. Let's come to the second classical question, durvalumab or durva alone. You look at the Kaplan-Meier curves, it looks the same. My reply would be yes, but we do not treat our patient or gain evidence by overlapping Kaplan-Meier curves. We do that on the basis of statistical analysis from large clinical trials. And I add the additional argument that monotherapy has never been as effective as the double checkpoint blockade, and that the duration of response, if you take secondary endpoints, much longer in the double checkpoint blockade within STRIDE that durvalumab alone. So that's to summarize my reply, I understand you might not be of the same opinion, but that's why we're here to discuss and to interact together.
Thank you very much.
Oh,
Thank you
thank
for the answer. Thank you very much.
Thank you.
I have 2 questions, sorry, Prof.
Please.
Yeah, just what's your approach for those who respond very well to immunotherapy? I mean, what do you do with these patients? For how long do you continue?
We send them to you, to downstage, and then they get surgery.
Even if they have, for example, extra abdominal lymph nodes or a distant lymph nodes or metastases.
We keep them treating this patient unless we are forced to stop. I'll make you an example, or 2 examples. I guess we as a younger shed a fibrillary carcinoma. That's something which is not usually responsive to traditional chemotherapy. So for the first time, we adopted double checkpoint blockade, ipi-nivo in this, ipilimumab and nivolumab in this case, and she had a complete remission. Metastatic, old body metastatic disease, 20 years old. And she has got a complete remission. But unfortunately, she almost died due to liver failure. So what we did, liver failure. So I killed her eyes and liver failure. So what we did was to treat her with a triple immunosuppression. And we braced for the moment when the tumor would come back over to this suppression. So, and never continued treatment, of course. Never resumed immunotherapy. But this girl is still, since by now 5.5 years, tumor-free. So that's a case where we are forced to interrupt immunotreatment owing to the very severe side effects. But we wouldn't have done so if we were not forced to do so. And the second case, if you wish, we treated a patient with STRIDE. He was a young patient. Then he developed hyperthyroiditis. And hyperthyroidism is a consequence of immunogenic thyroiditis. And he had a sort of psychotic episodes in the context of this hyperthyroidism. And he said, if that's the consequence of the drug, I don't want to have it anymore, never more. And he disappeared. And to come back 2 years later and ask us, hey, how about the continuation of my treatment? And now it's by now 5 years. So these exceptional cases in which you see complete response, as it was also the case for the second patient, the patient receiving initially immunosuppression and developing severe adverse reactions, which very often can be used as a marker, prognostic marker of response. So but otherwise, if your patient has a complete response, would you dare stopping treatment?
Well, difficult to decide honestly. But for young patient, probably sometimes we tend to discuss interfering with local treatment, including surgery.
There's also the financial toxicity, where you can decide not to treat them because they develop hepatitis or severe lung injury or whatever, and that's actual toxicity. But to keep this patient in treatment for 5 years means paying for the drug. Drugs are not cheap. Now it depends on the financial state of the patient, but if the patient is not treated, it does not have a good insurance. So you might at some point decide not to keep him on treatment.
So are you requesting biopsy for all HCC patients or just?
Yes, I would do so. I definitely do
prefer
biopsy in every patient, because sometimes you get a fibrillar carcinoma or oncology carcinoma. So the ESV criteria based on the kinetic of conscious medium during the imaging CT scan and MRI are not 100% specific. Probably 97% specific, and you never know depending on the local conditions. So we tend to perform a biopsy. So a margin of error 3%, I think is too much.
And are you using any, the molecular profile or any result from that biopsy to guide the treatment to decide between?
No, nowadays there is no biomarker kind of
Okay.
Not PD-L1, like in context to gastric cancer.
No immune score.
You do not have a score which is predictive of response first. But we get there at some point, but until then, you have to take a biopsy to confirm the diagnosis. And second, you can still do this biopsy for the molecular tumor board. So in practice, no patients get the molecular tumor board because, well, we have so many different lines of treatment now of basic immunotherapy. So we never get to the point when the patient has a genomic characterization which could trigger a further line of treatment. Because keep in mind, this patient had liver cirrhosis. After 2 progressions, the liver function, which generally occur within the liver function is so bad that he cannot receive another line of tumor-specific treatment. So that's a rare occurrence that we can perform molecular analysis resulting in additional line of treatment in this patient. But nevertheless, you can say we are taking biopsy for later until the plasmatic coagulation status is preserved, better taking biopsy now than taking it later. So there's 2 rationales for performing biopsy early.
What's your approach on immunotherapy and recurrence after transplantation?
Well, thank you for the question. I don't know whether you're putting this question. We thought about that because of our private experience or not, but we had the first group to treat patient with nivo after transplantation, and the first group to use atezolizumab to treat patient with recurrence after transplantation. Both cases, the patient did not have a rejection, so we were lucky. But when a lot of other colleagues report about organ rejection. Nevertheless, the basic question we are facing, the dilemma, why we are treating patient after recurrence after transplantation with recurrence after transplantation is what we are expecting is 100% likelihood that this is going to progress. So 100% of cases, this patient are going to die rather quickly under immunosuppression because of recurrence. And then on the other side, you've got organ rejection. And the likelihood of organ rejection is, I think, approximately 30%. And some of this rejection can be managed by immunosuppression, plasmapheresis, and so forth. So if you're the patient, of course, you would not recommend a first line of treatment immunotherapy, as effective as it might be. But the patient, you would treat him with sorafenib, but after progression of the second line of treatment, what would you do? You're facing 100% likelihood disease progression and 30% of organ rejection. So why not try? That's my opinion on that. Do you have this experience already in the post-transplant setting?
We have a couple of cases. We have one right now which has progressed on sorafenib. So we were forced. She did not tolerate. In our population, they don't tolerate full doses of sorafenib. You cannot reach the 400 milligram BD. They get a lot of side effects. So we gave her lenvatinib full dosing and just seeing, but I predict she will progress. So
never say never, because we have now a patient since 2016, since 2014. He was a colleague, a medical doctor who was still active as a surgeon, and he had developed HCC owing to hepatitis C, and 10 years prior, he had been transplanted. And then he presented in 2014 with a multifocal metastatic disease in the lung, and it was bioptically an HCC. And I gave him 1 blister of sorafenib, and he presented 1 week later, and he said, "Thank you. I'm a second doctor. I know my destiny. I'm not going to have it anymore." But then we de-escalated the dose. We treated the adverse reaction, and he's still there, and with stable disease and sorafenib. So it's worth trying tyrosine kinase inhibitors first before you do immunotherapy. Some patients do respond to sorafenib. Many patients will also respond to lenvatinib. So it's worth trying.
Well, this is what we did. But we'll see. But it is an interesting question in the context of transplantation and immunosuppression. Thank you. How many patients you treated? You said we treated several patients with liver transplantation.
No, not several patients, only 3, 4.
That's several in English.
Yeah. No, I'm being very careful not to overstate my experience
Thank you.
But I think it's 3, and the 4th is we have a candidate for immunotherapy now. That's progressing on the choosing candidates. But it's a very difficult choice because you bear the responsibility of a possible acute rejection from the patient's experience.
Question. What is the classical scenario, if any, to propose for a patient like systemic therapy or therapy plus local treatment like TARE, for example, TARES?
Yeah, if you want to have some slides on this topic,
Dr. Rashid is our intervention. Is it about?
Oh, okay. Then I'm really curious what you think about this, the use of immunotherapy and with TARES or TARE. Do you already have an experience?
No. Currently, our practice guidelines here is that we treat intermediate stage, usually with TARES. If it's a bigger lesion, has good alveolar bilirubin level, we can go for TARE. The gray zone is the BCLC stage C, where you have a large unilobar mass with unilateral portal vein or segmental portal vein thrombosis. This is where do we combine systemic with TARE or not? This is where maybe if you can enlighten us. But
yeah, we're very happy to do so. I'm really looking forward to seeing what you think about that. I can probably shorten a bit the first part of the presentation and we just one slide about how we can go from here to the future. We are going to have twofold combination of immune checkpoint inhibitors, atezolizumab and durvalumab. Tyrosine kinase inhibitors probably not good partner for a combination. So what can we do to push forward? Either we find some other checkpoint inhibitors, and there are several, like LAG3, which are available as a target, and meanwhile we have got the first approved corresponding antibodies against this structure, or we can go for the threefold combination. And on this, under this point of view, I wanted to mention the Montbahn trial is the first trial of durvalumab. So we do not have anyone now here the dilemma whether bevacizumab or not should be given or the tremelimumab should be given. We believe the threefold combination could be the standard of the future, basing on the assumption every one of these molecules impinge on a different stage of immune sensitivity, and this is the trial design. Either the upfront threefold combination, durvalumab at the beginning, in escalation of bevacizumab at the point. So thank you very much for your attention concerning the part of systemic treatment. I got some slides if you wish on the importance of staging, and you've been talking about gray areas. So we have got several gray areas in the BCLC algorithm. But the thing which I wanted to highlight here is the fact that we really need a staging algorithm, because if we obviously treat patient according to our own feelings, so to speak, I think in the long run we're going to decrease the survival on the life expectancy of our patient. But anyway, the controversial stage is BCLC-B, because we have got a very heterogeneous state. I think no one is debating about the Milan criteria. You can use the up to 7, you can use extending criteria, but there are rather stiff boundaries. And I think BCLC-C, the threshold from B to C is rather well defined by vascular invasion and exopathic spread, with the exception, of course, when you see you've got marginal total invasion and still can use logarithmic treatment together with systemic treatment. The problem is BCLC-B. The reason why we are arguing about BCLC-B is that BCLC-B patient can be rather heterogeneous. We have got, if you define BCLC-B according to vascular invasion, exopathic spread, everything which is within this with boundaries can be very heterogeneous. So you get very large tumors, so many tumors And as we have patient with impaired liver function or very good liver function, and we get patients with good performance status, bad performance status. And of course, you can, that perfectly being an interventional radiology, you perform angiography, and you see good blush, very well-defined tumor could be objective of TACE, and you see tumors which are diffusely infiltrating, and you don't want to treat with TACE. So there are several different factors, and this is the reason why with basically high heterogeneity of tumors, if you look at the meta-analysis, and of course heterogeneity in the outcome and these studies. And this is also the reason why we have a progressive increase in the outcome of TACE studies, because why we did this study, why those who did the studies learned that you can increase the outcome of TACE patients if you learn to select this patient better, so to speak. So you wouldn't, nowadays you wouldn't perform a TACE in a patient with a compensated liver cirrhosis and Child-Pugh score higher than 8. Some other researchers have more conservative say not beyond Child-Pugh A, and then you wouldn't treat a patient with extensive vascular invasion or with infiltrating growing tumor with impaired liver function or with bleeding horizon and so forth. So if you select patients, you have a much better performance of TACE. And then the question is, are we really following these rules? You all know probably these slides, and the answer is no, we are not really following the rules, because this is the stage in which TACE should be used. Of course, it could also be used as downstaging, the setting of transplantation and as bridging, or to downstage with surgery. There are still many physicians using TACE, BCLC, C. Excuse me for this shift of the description. This BCLC, C, and D, where patients should be treated with best supporting care. So there is still a fraction of patients who is inappropriately being treated with TACE, and if you do that, probably you decrease the life expectancy of this patient. One instance is this paper by Cooley that's been done in a small patient population, but it shows you that if you do not timely change treatment to systemic treatment from TACE, you perhaps do not a favor to your patients. He has decided to take here the up to 7 criteria, which define a systemic disease with respect to liver transplantation. If you do so, and you preferentially treat patient with lenvatinib instead, and it's not even immunotherapy, it's lenvatinib instead of TACE, the survival of this patient is improved. So this paper suggests that up to 7 would be the threshold where you should treat patient with TACE. I'm curious to hear what you say about that, what your own threshold here. So this is the summary of the first part, the introduction on the staging. Perform TACE only in BCLC patient. Consider several other factors which might influence the prognosis of this patient in response to TACE, like too many lesions beyond Milan, liver function, and the likelihood that you're going to perform TACE selectively, which is not the case in diffuse growing tumors. So, and the provocative sentence, if you TACE too much, you're going to kill your patients. Of course, I do not need to tell you, to remind you to be used to treat this patient. So we will say on the importance of staging. And now one word about the development of the use of immunotherapy in combination with TACE. This slide, which I did some time ago, and highlighted the role of bevacizumab and atezolizumab combined in decreasing median overall survival. We say median overall survival is not everything in life, but we have a strong increase in life expectancy measured according to median overall survival since the time of sorafenib, and probably we are going to expand this by use of sequential treatment with other drugs. And if we take response as a measure of clinical success of using the therapy, I would like to highlight again the effect of immune checkpoint inhibitors with patients with locally advanced colorectal cancer who has received a PD-1 blockade, and we had complete response in all of 15 consecutive patients. Of course, you know this paper, but as a paper which tells us that sometime in the future we might not even need surgery for some category of patients, provided you have good markers of response. So, which is the rationale for combining locoregional treatment checkpoint inhibitors? This is a schematic diagram of the assessment of clinical benefit basing on overall response rate. And if we assume we have about 50% of our response rate with locoregional treatment, that's about what we expect from TACE or TARE, 40 to 60% overall response rate. And we take 50% of our response rate BCLC-B, so the fraction of BCLC-B patient which has been treated with immunotherapy. So we will have theoretically a 17% overall response rate, not 100%, because it will be still some patient will not respond. So the first obvious advantage of combining the treatment is that we are going to summate the advantage. The second rationale underlying the concomitant treatment is that we have high survival rates plus an X fraction of patients probably profiting additionally from the combination because of effects like the abscopal effect or through some other process of sensitization to the effect of immunotherapy owing to antigen release when the tumor has undergone embolization or radiation treatment, for instance. And the third rationale, which I like most personally, is that every kind of locoregional treatment is causing some extent of non-intended liver damage. So whenever you do a TACE, you do TACE very selectively, but nevertheless, it's unavoidable that some of the embolizate goes outside the target region, and you will end up with not only with increase of transaminase, this is the optimist trial, but also not only with increase of transaminase, but also with an impairment of coagulation parameters, so bona fide indicators of liver function. So the less you treat with TACE, the better it is. And if you combine two modalities, immunotherapy and TACE, owing to the effect of immunotherapy on tumor response, perhaps you have got much less need of using TACE repeatedly in this patient. And this might cause a beneficial effect because you save liver parenchyma if you do so. So the second point is with sequence, you can use immune checkpoint inhibitors before or after the treatment. So first TACE and then immune checkpoint inhibitors, or first checkpoint inhibitor and then TACE. And we have got different advantages and disadvantages of the approaches. And the most evident one is that if you use two approaches combined, probably get a more robust response in the beginning of treatment. If you use them afterwards, you've got a possible you've got an advance in terms of toxicity, but a possible delay in response. So this is the situation. So I would like to show you just two clinical trial concepts. This is the DEMAND trial. This is the first trial combining atezolizumab and TACE, and we have got two different treatment arms, arm A and arm B. Arm A we use, arm B we use TACE plus atezolizumab, everything together, so triple treatment, and then see what happens. And in arm A we start with atezolizumab, and then we observe the patient, and then we treat only whatever keeps on growing. So we treat only lesions which are resistant to the action of checkpoint inhibitors. And the rationale is that by doing so, we avoid unnecessary treatment to lesions who would respond to immune checkpoint inhibitors. And the second trial is about TARE and the use of combined durvalumab. And we got here three different arms. One is a personalized set of TARE with durvalumab. This is with a fixed dose set durvalumab, and this is in analogy to the arm A trial. First, durvalumab and super selective TR on demand. So in summary, to wrap up my message concerning the use of immune checkpoint inhibitor treatment, as a rationale for combination, we have this summation of therapeutic effect, possible synergy, and capital protection owing to reduced need of using repeatedly TACE or TARE. Challenge for clinical trials, of course, to define the most appropriate combination of agents. We do not know whether Tazobactam is better to training, for instance. We do not know whether TACE is better than TARE in sensitizing tumor cells to action immune checkpoint inhibitors, for instance. And we don't really know exactly still with the optimal sequence. So I think there's enough stuff to discuss about. The third chapter is about the ideal treatment in the post-surgical setting, if you want.
Yes. What we do here in the MDT, we are quite strict here. So anybody who has performance status 1 or under 1 or any vascular invasion or lymph node metastasis or multifocal disease, which is quite extensive, we usually treat with systemic treatments. So Barcelona classification C,
Yes.
systemic treatment. Now the B, which is not common, what we have seen in this MDT, Dr. Rashid might get from other hospitals.
B.
So the intermediate, we usually they are treated with local regional disease, and we have not been adding any kind of adjuvant or any kind of other medication or adjuvant treatment. Basically, because sorafenib, the STORM study, was negative. Belimumab is a Chinese study which has not been replicated. The IMF grade 50 is interesting, but still has not been accepted in the NCCN guideline. So we have not employed it. So this is the current position that we are practicing right now. Local regional treatment for intermediate personal KMB with no additional KPIs as such. There is an interesting group where there is macro or microvascular invasion, post-resection. There is a reputed benefit from TACE in these patients, but we rarely see them as after surgery.
Yeah, I completely agree with you. I think we have to do what the guidelines say. And usually the guidelines are based on a strong evidence. And so I totally agree with you. We should not use combined treatment outside studies.
Yes. Anyway, we have a PNT committee here in this center that will not allow us to use any medication without being vetted. They would look at the NCCN guidelines, they would look at EMA, they would look at NICE, they would look at ESMO categorization, what category is given, and then they will give you the drug. So
yes,
it's unlikely that we will escape that.
No, but something, but there is an exception to this concept. For instance, if you have a BCLC patient in multifocal tumor, let's say he has got 7 lesions. You perform a 7 lesion and 1 extrahepatic lesion, lung lesion. Now you are treating him with durvalumab. He has got a response in 3 lesions. You perform the staging after 1 year, and you've got 1 lesion growing in the liver. 6 lesions are gone. 1 lesion is growing in the liver. What do you do?
A similar case like this, like Dr. Abdullah, remember that patient with the lung that's with the liver lesion, and we did radiofrequency ablation for the lung, and we treated with systemic treatment.
Yeah.
So it depends on the case, but this scenario that you are raising is got a very good response we will probably go for local region treatment for the ones that are out of chronic, but we'll continue the system.
Exactly. That's the classical case. This is exactly the opposite speculative situation. But maybe there is no guidelines writing, at least not to my knowledge, the local region treatment should be used in BSCC patients with limited progression of one lesion. Once the test of time showed that under immunotherapy, the biology of the tumor has been slowed down and the general response has been achieved.
Just, I want to ask you, in this category, post-resection, there's a category which is called high risk, as defined by the Chinese study. Tumor size more than 5 centimeter, macrovascular invasion. Do you offer them anything? Or do you offer them lenvatinib, for example, elephant?
No, we don't. All studies of adjuvant treatment are negative, except the IMbrave 050 trials. Can you slides here? That's the trial. You all are aware of this trial. Probably this was done with atezolizumab in patients which had been resected or ablated, and the risk factors are here well defined here. I think this is the risk factors you're referring to. If you look at the risk factors, they resemble rather closely the Milan criteria. So the magnitude of the lesions and the number of the lesions, and of course the vascular lesion. So and the trial was positive. So now I'm curious to know what you think about this slide. You know already this slide? Yes. So what do you think? Would you offer atezolizumab to your patient with high risk constellation?
That's the question.
Yeah. This is the post-resection. So this is.
If they need the
This is a recurrence-free survival. So of course you never do such studies in the adjuvant treatment with overall survival, because when you only ever get really the results of the trial for the next 10 years probably. So we need recurrent-free survival as a surrogate of the efficacy of the adjuvant regimen. And you see here, this result is spectacular. But we see a problem with this slide. The results are spectacular, but after 4 months, basically they're exactly the same amount of recurrences. Only this patient had got the recurrence a bit earlier and this a bit later. But in fact, he had the same number of recurrences. So is it relevant or not? My personal opinion is that it's relevant. And we will see probably at some point when the data become more ripe, when we have survival data. But what really makes a difference between sorafenib and the immune checkpoint inhibitors, like atezolizumab, is that immune checkpoint inhibitors are causing a clearance of cancer cells. They're causing response. Sorafenib has got more a cytostatic effect, but it's not clearing the cells on the organ. So, based on this rationale, I think that there had been here a clearing of cells, which might affect the pattern of metastasis and recurrence as we see them. So I'm the opinion we do not know that yet, but I think that these recurrences here numerically are the same as the recurrence in the control arm. But qualitatively, they probably are different. We don't know where the metastasis come from. Is this a local recurrence? Is this distant metastasis? Is it intrahepatic metastasis? And this makes a huge difference in terms of prognosis. I'm not aware about the fact that this data have already been disclosed, but I am optimistic that the treatment might have a good influence on the eventual outcome of these patients.
I think mixing the post-hepatic resection, where we don't have visible disease, with the ablation, where we did they took two groups of patients.
Yes.
Post-hepatic resection and ablation. And we know that the immunotherapy, the anti-angiogenesis work better when there is a bulk of tumor. So would it have been better to design the trial only for the patient who had residual
Yes.
tumor like ablation only.
Yes,
I think the weakness, in my opinion, is the mixing of the two populations.
I think so too. I think so too. And also, if you get more the tumors, the likelihood that the outbreak happens is more. I mean, you look at the including criteria, and I mean, you have got one tumor larger than 2 centimeters here. Is that really high risk constellation? I don't think so, but nevertheless, it was included in the trial. So the trial might have been weakened also by the fact that there was some patients who were really not at risk of recurrence.
Maybe concentrate on the last group.
Yes, yes, I think so too.
Thank you very much.
No, thank you. Thank you for the very nice
Thank
exchange.
you very much. Any questions? Thank you very much.
Thank you, Director.
Thank you.